right, hello. So it's a stormy, blustery day today, and I'm recording this, and I am using a handheld Zoom recorder because I figured if I'm gonna record this, I may as well play it up a bit, get some of this, go with the stormy noises, right? I mean, if I was considering, I'm noticing the medium of Substack is getting more and more popular, but I I'm choosing to do it this way because you get some stormy sounds in the background, right? There's something about the process of recording my voice and talking about it that I think is inherently different from the process of writing it down or posting it in written form. Although I've written out some notes here that I'm going off of, sketched out an outline of what I plan to talk about. So there's a bit of both, right? This is not just talking about stuff. It's all or whatever. I'm getting it's kind of a distraction, right? But this is I'm. It's also, I should mention, a full moon today. A full moon in Gemini during Sagittarius season. I do an astrology channel. Um, I'm just making note of that, but that's not what I plan to talk about right now. What I'm talking about is um, basically about psychiatric diagnosis is on my mind today, and more specifically, the problem of the DSM diagnosis. But I'm using that mainly as a starting point. And I have I kind of go all over the place. But the basic premise is that I know that it's a contentious issue, the DSM and diagnosis, and I know people, internet friends and stuff like that who are like really extremely against DSM diagnosis, medical diagnosis, the medical model, all that kind of stuff. And I'm sympathetic. I'm not sure if I'm entirely on board with that way of looking at things, though. But I'm for people who really just want to reject the DSM. I'm sympathetic with the inclination to do so. But I'm just I've been thinking about this for a while now, and there's a certain kind of I don't know. Jung had this word enantiodromia, which is like you go so far in one direction that you come around the other side, right? Or that another thing that I noticed is that personally, a lot of my own sentiments involving anti-psychiatry, or resistance to the medical model or the psych system, it stems directly from the experience, like the first-hand experience of dealing with the people working in the system and not liking it, and that I have basically I managed to get out of the psychiatric system in 2016, and at the time I'm recording this, it's 2024, December 2024, so almost 2025. So that's like we're coming close up to 10 years away from the psych system. And so there's a certain gap, right? There's a gap between the first-hand experience of dealing with the psychiatric system and thinking about the having a gap where you're not having to have the experience of going into a psychiatrist's office and dealing with the professional who is doing the labeling, the diagnosing, the prescribing, and stuff like that. And if I was in that situation, I may be, I may not be making this video, right? I may not be recording this, or I may have a different perspective. But having a nice, good, 10-year gap where you don't have to deal with these assholes, you can sort of take out the, you can look at it in a more dry way where there's less like personal involvement with the problem, and you have some distance from it, right? It's not so up close and personal with the problem. You've got some distance from it, so you can look at it in a more cool-headed way, maybe a more critical point of view. and not be rush into not rush into this whole thing of just rejecting it all entirely. And so what? But there's still obviously I'm sort of taking the approach maybe of a bit of like a devil's advocate for the DSM, or at least a defense of the DSM, even though I recognize why people don't like it very much. Um, but in order to do this, first of all, I want to start by making a distinction, right? And the whole, I mean, also to emphasize this, the act of making a distinction, right? Because this will we'll come back to this later. But first of all, is that we're going to make a distinction between the process of diagnosing and the process of prescribing, right? Because I think one of the main problems here is that a lot of the conversation gets bogged down into issues to do with medication, with and like like creating a dichotomy between of being either anti-meds or pro-meds. And like if you're at that such a all of the people in the anti-psychiatry or critical psychiatry movement are always careful to say that they're not it broadly anti-meds, because maybe there's somebody out there who the meds are it doesn't make sense to make it a completely fundamentalist position against a certain form of treatment or whatever. However, that being said, my exit from the psychiatric system also was motivated by my exit to come off meds, and I have been able to be off psychiatric meds since. Well, basically, 2016 was the year I got out of the system, and I spent a whole year tapering, and I got off the medication in my own initiative, with some support, but not support of the mainstream medical system, right? But the main point, first of all, to make the distinction between the diagnosis and the prescription, because it's just a whole other conversation, basically, and that I think part of the problem is that these two things are so intimately linked that we conflict. We don't see the distinction. We just see one thing and the other thing, and by making the distinction, it allows us we in this conversation we can focus more on the actual problem with the diagnosis and the DSM, and not get hung up on the forms of treatment, which would be we can see that as another conversation, right? Because basically there's this the question of the diagnostic categories themselves, and are they accurate, are they helpful, are they useful, or and then on the other hand, then you can look at the process of treatment, right? And that you could say that in some cases a diagnosis may lead to a certain kind of a treatment, but that could be a contingency, right? You could say this is a diagnosis. This is what the recommended treatment is. Does the person go for the recommended treatment? Yes or no, right? And the problem with forced treatment is they want to make this into a yes all the time, right? Everybody who has this diagnosis has to have this treatment in all cases with no exceptions, right? But if you accept the fact that these things aren't inherently, there's no real imperative. I mean, you may argue otherwise, but I'm arguing that there is no real imperative to have these things completely connected, and that we can disconnect the imperative to treatment from the diagnosis process itself, to just look at the diagnosis process, right? And so my defense is more about the defense of the diagnosis than it is the defense of the treatment, right? Now, to start with, there's certain things that I have firsthand experience with, and certain things that I don't have firsthand experience with, right? And that personally, my firsthand experience is to do with what is considered to be either like the bipolar, schizophrenic, psychotic spectrum. Although my experience in the mental health system, they've always been kind of vague, and it doesn't really seem, they've never been that clear about exactly where I fall on the spectrum. Although I've never been diagnosed with schizophrenia proper, because I think I tend to be a little bit too, I don't know, extroverted, I guess you would say, in that sense. or expressive, or because there's the idea that schizophrenics, in the classic sense, are very shut down, very flat affect or whatever, and that they create this category called schizoaffective, which is supposedly a in between the schizophrenic and the bipolar, which is not quite as shut down as the schizophrenic, right? So that's what I have firsthand experience with. And there's also I think there's a certain gender element to this, because I have noticed that there are certain diagnoses which are seem to be more prevalently diagnosed with women. For example, like it's borderline personality disorder is usually characterized as a in women. It's probably much more rare for men to be diagnosed with borderline personality disorder. Um, and also, there's this other thing about eating disorders, where I suppose there are probably men out there who have issues with anorexia and bulimia and all these kinds of things. But it seems like there's something about it which there's like certain cultural thing that has to, women's body image, the pressure to look a certain way, the pressure to be a pleasure object for a man, to be appealing or something like that, or to have control over your body or something like that. And I think with a lot of men, they may, due to maybe gender dynamics, there may be a less. I mean, there could be a lot of men who have these issues too, and we just don't know about it. But in my mind, it seems more there's a certain gender coding around it. But I'm using this as an example because, okay, bulimia, for example, something that I don't have any personal experience with, and something that it's something that I personally could not relate to, or personally something that I could not, I can't really sympathize with the impulse to do that, or I couldn't really imagine myself making myself throw up or something, right? But I think I'm starting with bulimia because bulimia is an example where it's like there's no ambiguity with bulimia, right? Bulimia is a very specific behavior, and in this case, I think it's fairly black and white in the sense that you are either behaving this way, acting this certain pattern out, or you're not, right? It's not really like you either went into the bathroom, induced your gag reflex, puked out the food you just ate, or you didn't, right? It's a very specific, and there's an objective material component to it. You're either puking or you're not, right? You see what I'm saying? There's and so in that sense, there's something about a if your if you are diagnosing someone as having an eating disorder, there's a very tangible material component, right? Because there's this material reality to the food that we eat, and what your relationship to food with. That is your relation to the external world, you putting food in your body, you digesting that, like your physical health that could be affected by your nutrition and stuff like this, right? So there's a very obvious material component to eating disorders, and this is contrasted with what I would contrasted with other forms of what's considered to be psychiatric disorders, because some of the symptoms of, let's say, a schizophrenic may be things like visions or voices or delusional beliefs or something, which are basically, you could say they're subjective in the sense that they don't have the same material ground objectivity that the active bulimia has, right? There's no, if, let's say, the person keeps quiet about whatever symptoms they have, there's no way for an outside party necessarily to observe and diagnose that, aside from whether the person chooses to disclose or chooses to describe. And then even if they're disclosing and describing what's going on, we're limited by there could be some things which are difficult to put into words, right? Difficult to express in language, difficult to communicate, and you're only basically doing your best by, doing your best with your grasp on language and your ability to communicate to people who may not even, there could also be things where like communication obstacles where two people may be able to have a conversation fairly easily that another two people wouldn't be able to have, right? And in a certain situation, if you're able to communicate things clearly without too much misunderstanding, that's a different kind of dynamic than if you try to communicate something and the person thinks you're crazy because they don't understand you, right? Like, so there's an element of being just maybe being the judged as being crazy or being insane because you're misunderstood, right? And also because not just because you're misunderstood, but because you are trying to do your best to take a internal experience that you're having, figure out a way to put that into language, can communicate it to the other person, and there in that whole process there may be all sorts of places where you run into problems with that process, and that the person doesn't have direct access. If to compare it to you go to the washroom, you open the door and you walk in and somebody is throwing up their lunch. There's no interpretation there. It's a brute fact, basically. There's a brute fact of a behavior taking place, and there's no ambiguity about it at all. Whereas if you have a personal subjective experience that the other person has no access to aside from how you determine the best way to communicate it, there's a lot of room for ambiguity there, right? So, and basically, I mean, to introduce what I'm trying to say here is that even if you disagree with there's all these other issues about pathology, pathologization, and stuff like that. If you regardless of all that, there's still a categorical difference between something which is just plainly obvious as a brute fact and material reality versus something which is much more ambiguous and potentially undetected unless there is an effort made to communicate. So, I mentioned the whole issue around pathology, right? And one thing that I kind of ran into recently is this question of why is it such a bad thing for something to be pathological, right? Or why, like, this is maybe something that I got from being involved in what you would call the MAD movement or the anti-psychiatry movement and all this kind of stuff. And I don't know, to give you the rundown of where I'm coming with this, there's a certain attitude around non-pathologization which uses as an example, let's say, homosexuality, transsexuality, all this kind of stuff like that. That at one point in time, if you were gay, lesbian, trans person, any sort of queer, like you were basically that was deemed as a pathology in the sense that it meant that there was something wrong with you, that you were disordered and in need of being corrected, and you were being treated as if you were mentally ill, right? There's also interesting if you look at the history of psychiatry and the history of mental illness, that it's not just limited to like the gay, lesbian, queer dynamic. There's all sorts of things like if a woman was promiscuous, right? Then she would be it would be kind of a moral indecency to sleep around or something like that, and that would be considered also a form of pathology, a form of illness. Maybe we still maybe there's still moral judgments people have about that kind of stuff. Or progressive attitudes that want to, slut shaming, that kind of attitude, right? I'm just using there could be like somebody who's like chronically like late for work, right? Or like things like some people who are tardy, people who are who have bad habits in terms of like keeping their house clean. Or there's all sorts of things like this which are like, there used to be all sorts of things which were considered to be mental illnesses, which could also be like, I don't know, flaws of character, or like Thomas Saz would say, trouble in living, right? Um, so basically, there's a whole conversation around pathology and not pathologizing that's connected to this idea that in the olden days of psychiatry, there were lots of things that were pathologized, and as historical progress moves on, there's gradually less and less things which are pathologized, and they're viewed under a different kind of a light, right? But I think there's still some a kind of a defense, or maybe this idea that we can like redeem this idea of pathology, in the sense that if you the root word of pathology is pathos, which basically means a kind of a pain and suffering, right? And that at this very basic level, to say somebody has a pathology is sort of like in a in a medical context, saying you have a pathology is like saying you have an illness, or you have a disease, or you have an injury. And if a person has a kind of a affliction, a psychiatric ailment, an affliction or whatever, if the person is suffering, if they're not having a good time, if they're having difficulty with their life for whatever reason, then it's just the way what the word is supposed to mean, pathology, is I don't think it's inaccurate or wrong to say that if a person is suffering, having difficulty, having a problem, to say that's a pathology is just saying that there's evidence of some issue that's causing distress or discomfort or difficulty in a person's life, and that the person is coming to a professional, to address this problem, right? And that so I honestly don't think there's anything inherently wrong with the idea of pathology itself. But if you look at the context in which it's used, if you look at if you're pathologizing homosexuality, then you are making a judgment on homosexuality, saying that it's inherently wrong to be homosexual, and that people who are homosexuals need to have like conversion therapy or something like that. Which is that would be something that is kind of gone out of favor, or has a lot of the people don't like it when it's applied to that. But if you apply it to all sorts of other things which we still consider to be psychiatric diseases or psychiatric ailments, then it's fair to say if someone's having a bad time and they want help so they're not having such a bad time, it's fair game to call it a pathology. Why not, right? There's another issue though, that some people point out that there's a reason why we don't want to call it a pathology, because the pathology, by the basic way the DSM works, is that if all the ailments, the disorders, the pathologies in the DSM, in order for it to count as that kind of pathology, it has to be a issue with the individual, as opposed to a sort of a collective issue, right? And what I find interesting about this is that even I have to admit, I haven't read a comprehensive amount of Sigmund Freud, but if you even just stick with the basic, granddaddy of psychoanalysis, Sigmund Freud, there's this paper that he did on hysteria, where he was talking about a patient of his who basically suffered some disparaging comments or being humiliated in his workplace by his boss, and that caused him to drop out of work and have I guess you could call it a complex around it, or but Freud describes it basically as the idea of this is the context, like it's a pathology, right? It's similar to having an injury. Like you could talk about like basically like workplace injuries, right? In this, like making, so many people often do this thing where they say like, there's all this stigma around mental health, but the thing is, we don't have the same kind of stigma around physical issues, right? Like physical injuries, physical ailments aren't taken personally as like a personal character flaw in the way that a psychiatric disability or a psychiatric diagnosis is, right? So, but if you consider this example from Freud about you could just look at it as, if you take the idea of a pathology, a medical illness or a psychiatric illness. In a medical paradigm, let's say you're working on a warehouse and something falls off the forklift onto your foot and you like break your ankle. And then you have to go to the hospital and then you get a workers' comp payout, and it's seen, basically the people who employ the people at the warehouse will be like, okay, so this is something, it's just statistics, right? That there's only a matter of time. If we're working, there's only a matter of time before some accident happens to someone. We try our best not to have at workplace accidents, but it's just one of the costs of doing business. There's always some risk factor that your employees are going to get hurt, and so we have something like workers' compensation that pays out a certain money to the worker to give them some time off to heal from their injury, all this kind of stuff, right? But it's not taken unless maybe the worker was being reckless or something like that, and they were being sloppy or something like that, But there's still this basic kind of like workplace injury thing. Where it's not taken to be such a character flaw that if you have a physical injury, right? But the same thing is that maybe you have a really big conflict with a coworker or a boss, and they say really bad things about you, and then you have a psychic injury around this, which doesn't have to do with a physical part of your body. You don't have to take it so literally to say that you now have that because your boss said bad things about you, your brain is damaged or something like that. But you can say that you have a wounded sense of self. You have a wounded sense of character, right? That you, instead of having the self-esteem that your friends and family and coworkers all think highly of you and will sing your praises, you are afraid to show your face because the people around you will ridicule you, laugh at you, tease you, bully you, all this kind of stuff, right? And that from the point of Sigmund Freud is that this is in the sense of that a pathology in a physical sense could be like, something falling off the pallet in the warehouse and crushing your foot, and now you've got an object, and you've got trauma, and you've got an injury, and you've got a pathology. You could have the same basically causal chain, but instead of it being inanimate objects, you have it happening at the level of people and personalities and characters and interpersonal connections and stuff like that. You see what I'm saying? And that the idea is that so you have interpersonal traumas that had the same. Freud basically was taught. Freud explicitly said that there's a causal. It's like in the same way that if something, sticks and stones will break your bones, but that kind of thing. It's basically that. There's like a causal thing where this thing makes that other thing happen, and because it's like if you're working as a doctor, it's going to be the person who's been injured that comes in for treatment. It's not going to be the thing that fell off the pallet or the boss who made the disparaging comments or something like that, right? There's something about the whether or not it could very well be that the other parties involved have their own psychopathology, right? That is causing them to be bullies or to be rude or whatever. Or it could also be like, I don't know, maybe to be completely just trying to not take sides, not be biased. Maybe, I think this is perhaps a point in tension in the whole anti-stigma thing, because the whole anti-stigma perspective is that they don't want pathology, psychopathology, to be interpreted as a character flaw or a shortcoming of the person, or something to identify you with. You are a bad person, and and that having the illness, you have that illness because of your own poor choices or something like that, or you're just a weak, you're just a weak, sorry ass weak person that nobody likes and it's your fault kind of thing, right? The people don't find those attitudes helpful, so they try to steer away from that with anti-stigma. But from the perspective, if that's the dynamic where somebody is traumatized through certain interpersonal connections, and that the other people that are either bullying the person or making disparaging remarks may actually feel like, yeah, this person, they don't like the person, right? They have some kind of motivation for why they are behaving the way they do, right? And it's maybe too complicated to address whether that motivation is due to those people being, assholes themselves, or being or like having their own sickness or something like this, or maybe their own issues that are then being acted out onto some other party. But then we don't want to also. I mean, this gets kind of complicated because there's this whole problem of like a kind of an innocent victim or a that kind of stuff like that. We're not going to get into that right now. It gets a bit too complicated, right? So that's basically this is addressing the whole issue of pathology, right? And I think that at the very basic sense, regardless of whether or not there is fault in if it's like, specifically, it's kind of obvious that if there is also forms. I'm just using that Freud example of the workplace incident as a specific example, but there could be all sorts of, if somebody was, abused, right? It's fairly more. It's not. I don't think it's very morally ambiguous to say that if a person is the victim of some kind of overt abuse, overt sadism or cruelty, that it's not the victim's fault for being a target of abuse, right? Or it's not or that there's some kind, and there's this kind of thing of like there could very well be something wrong with the person who is the abuser, but the thing is, it's kind of like, if you may have a situation where the person who is experiencing the problem is the one who goes in to seek treatment, and from the position of the person who is a abuser or a bully or something like that, they may be less inclined of their own initiative to go in to like get counseling or therapy or something like that to work through their pattern that causes them to victimize other people or something like that, right? So it's just it's like I think if you look at where this all comes from, I think there's like, you don't need to necessarily say that pathology is all just to do with the person the person themselves as a entity that just exists on their own without all these interpersonal dynamics which lead to the problem in the first place. That that's sort of like this sort of you have to look at the situational context from which the problem arises, right? And then I'm rejecting this idea that pathology inherently means that it's just this individual thing going on, because like you could have a pathology, you could have an injury, you could get hit by you could have a gunshot wound, right? And it was obviously that the person who pulled the trigger and shot you, it's obviously that you didn't, this bullet didn't just come from nowhere. Maybe like maybe the person has a motive for the attack or something like that, and there's this whole other dimension to it that's not medical, right? There's this whole, the same way that the psychopathology may have this whole other dimension to it that's not just in the realm of psychology, right? Or or it could everything be viewed psychologically, right? But what I'm saying. I started this conversation talking about distinctions, right? And that there's this whole making a distinction between the individual and the individual's ailment, the individual's disease, the individual's pathology, and the causal chain from which that injury arose, and the different actors that participated on that causal chain, and whether this was the injury was accidental or intentional, all this kind of stuff, right? That basically there is this process in the system of diagnosis of looking at the person on their own without taking in consideration the whole situational context, or not bringing in the other parties, not looking at the chain of cause and effect, all this kind of stuff, right? Although and this kind of leads. I'm trying to use this idea of where they're looking at things in terms of these different pieces or parts in a kind of causal chain of things happening, right? Like, or just specifically looking at the person and their own suffering, and you give them a drug to make them feel better, or you give them some therapy or whatever it is, right? There's this system of diagnosis, right? The person comes in with a problem. It's a pathology in the sense that they're suffering and they want to feel better, and there's a treatment that supposedly helps them to get that outcome, right? But the diagnostic system basically is a form of categorization where you categorize a person in a certain way, and following that category, it leads to a prescription protocol, right? A treatment protocol. Now, there is some basic issue around this that I feel like exploring, right? Now, I mentioned before, in my mind, there's something inherently different between something like, I said, eating disorders, because they're more materially obvious, and other kinds of ailments which may be harder to have an objective grounding to, right? It's more if your moods and emotions may be more subjective than objective, right? Or if a person is, let's say, schizophrenic and they hear voices, the whole point of that is that the other people around them aren't experiencing the same thing. Whereas if that person was a bulimic, the other people would very much be, they very much would be experiencing that, right? So there's this inherent difference, I think, right, between one kind of problem and the other. In the same way, there's an inherent difference between a physical injury, like having a broken bone or something, and having a psychic wound, right? If you want to put it that way. Now, there's also, in the process of the way that they do, there's something interesting though, because oftentimes these things can overlap. You could have and this is why I think that there may be some merit in the DSM perspective, because you could have a person that has all sorts of different, they could have borderline personality disorder, they could have anorexia and bulimia, they could have bipolar and schizophrenia, and they could have obsessive compulsive disorder, all happening at the same time, right? Now, there's this thing which happens where you're like, okay, so we need to determine how we're going to treat this person and what services are available to them, all this kind of stuff. And let's say, and so we're going to avoid the whole medication topic in this particular conversation. And I'm going to talk about let's think about support groups or something, right? Let's say we're going to have a support group for people who are bipolar, and we're going to get everybody. We have this group of people, and we're going to select all the people who are bipolar, and we're going to separate them from the other people, and then we're going to put them into a support group, and then so all these people with the same problem can talk about the problem, right? Now, when you do that, it could be very well that in the support group, some of these people have anorexia and bulimia. It could be possible that some of these people have self-harm behaviors, right? Like cutting themselves or something. It could be possible that some of these people have experiences where they became delusional and thought they were Jesus Christ or something, right? I'm just kind of using some basic examples, right? But the thing is, you could have, so you have all these people that have been selected and put into a group, into a category, because they have this one thing in common, but then you also see that they have all these overlapping things that they don't have in common. So then, alternatively, you could start a support group for people who have, let's say, anorexia and bulimia or eating disorders, and then you have the inverse problem. You could have a whole bunch of people who have eating disorders, and then some of those people that are in that support group have eating disorders, but they also have bipolar mania, or they also have obsessive compulsive, or they also have anxiety and depression, or ADHD, you name it, right? And the thing is, you're always going to have these overlaps going on, and the thing is that there's something interesting about this in that we start to think about these conditions as if they are their own entities, right? That there's something that is like this thing that's called bipolar, which exists as a definitive thing outside of its imminent manifestation in a person. But the truth is that it doesn't. There's no way that you can have any of these existing outside of the person themselves, in which the thing arises and is interpreted to be such and such a thing, right? It doesn't, there's no platonic world of forms or something, or some sort of perfect, unless this is kind of what the DSM pretends to be, right? Like some manual where all these things exist in some pure form, separate from the inherent messiness of the actual circumstances in which they arise, right? So all these things arise in actual real people and they're mixed up with other things that they overlap with or co-arise with, right? But in the process of diagnosing them is basically to divide one thing from the other, which is, in some ways, I think it's relevant, because if you're trying to understand what's going on with a person, you basically, I think the eating disorder is a good example, because it's just, like I said, it's a brute fact, right, of whether or not a person either has this behavior or they don't, right? And there's no ambiguity at all when it comes to that, because it's something that's very material, right? Whereas when you start to get into things like, let's say, schizophrenia, bipolar, obsessive compulsive disorder, borderline personality disorder, all this kind of thing, I think there are certain patterns which maybe, you can spot similar patterns in, different people, but it's something about it which is, it's more subjective, and it's less just a specific objective thing that you can measure, or that you can objectively say that this thing either is there or it's not there, right? And there's another sort of thing that goes with this, is that there's a certain legal component as well, where people are, if you have a certain diagnosis, you may even be, in the UK they call it being sectioned off, right? Which is you fall under a different, you have a different set of rights now, in terms of, the authorities could just whisk you away and trap you in a hospital, hold you there against your will, because you are now sectioned, right? So that I think this is one problem with the DSM, is that for something that doesn't have very strong objective material basis for diagnosis, this can be used to create very hard categories, right? Or very hard, there's creating these boundaries, or creating these hard divisions between the person who is diagnosed, sectioned, and the rest of society, which kind of goes with this I'm not. I can't call myself a Foucault scholar, but apparently Foucault talked about this in terms of Christian pastoralism, right? The idea that you've got the pastor whose job it is to look after his flock, and for the good of the community, it's sort of like you need to take people and basically outcast them, because if these people are part of the community, they're liable to have a bad effect on other people. So we need to basically separate these people and isolate them and keep them in a different kind of living. And basically the whole premise of the old institution and the asylum is built on this, is having a different place where there's a different set of expectations for people, where you're not expecting these people to be productive members of society. They're isolated and separated off and living a totally different life than the people who would be integrated into the community, right? But there is an inherent problem with this, because like I said, there's not really an objective material basis for doing this, because it's basically all just interpreting behavior, or interpreting what the person communicates about themselves. You can't spot it on an X-ray or a CAT scan or something like that in the same way you can do with real medical diseases, right? But I think there still is some. It helps to have these ideas of different categories, or to say that something like an eating disorder or personality disorder is maybe different than a schizophrenic or bipolar kind of disorder, right? There's another problem in that if you were to just look at, if you were to have a whole bunch of people who were mentally ill, and then select out of those people all the people who were schizophrenic, and then put them all in a room, and then look closely at what their actual experiences and symptoms are like, you may find something where people they don't, for people who supposedly share the same thing in common, you may notice there may actually be a lot of differences, right? And this also kind of applies to the idea of autism, in the sense that not everybody diagnosed with autism has the same symptoms. And also, it's also pretty obvious that not everybody who suffers from autism has the same severity of the problems, right? There's some people who, and which to me this is kind of interesting. I don't claim to know anything about autism, but to me it's interesting that you can have, the spectrum is so wide that you can have people who have really, really stark contrast between the level of severity of the problem, and yet it's considered to be essentially the same thing, right? What kind of leads me to wonder, like, why wouldn't it make more sense to create a more of a hard distinction between a severe form of autism or a mild form of autism, right? Or like you to talk about in terms of like more functional forms of autism versus a person is more disabled there, they have more trouble functioning, right? There's this problem with schizophrenia, in that, like, there's certain symptoms that some people have that others just basically don't have, right? There's this one about word salad or disorganized speech or disorganized thinking, and there's some people that just don't have this issue the same way other people do. And this has led people to speculate that what we diagnose as schizophrenia could itself be a number of different conditions that overlap with each other, and that you may have some things overlapping and something, but it's also kind of, it's in a way it's the same extension, the same way that, maybe somebody has bipolar, borderline, and an eating disorder, and it's all just together in the same person experiencing all these different things going on at once. You could have this person who has schizophrenia and they have, X, Y, and Z symptom, whereas another person has A, B, and C symptom, right? And that they may be completely different in what they experience, but there are they're just somehow it gets. We just have. This is one reason why I specifically do not like the schizophrenia diagnosis, is because there's so much variety or difference in the people that have it that it's not. It doesn't seem to be very accurate, right? Um, there's I think there's a theory going around that schizophrenia may actually be 8 different things that happen together that sometimes overlap and sometimes don't. Um, and the funny thing is that it's like there's some underlying problem here in that we have this tendency where we want to isolate each one of these things and have a clear definition of what it is, but when you actually look at how it comes up in real life, it doesn't come up as a separate isolated thing. It usually comes up mixed in with all this other stuff going on, right? And then to further complicate it, we're just talking about psychiatric stuff. What if the person has other ailments that aren't immediately relevant to the psychiatric thing? Like, let's say a person has like multiple sclerosis. Well, let's say a person has diabetes. Let's say a person has Parkinson's. Let's say a person has, any number of or whatever. Any like there's certain things which are may happen more often in schizophrenics due to medication side effects, right? Like as antipsychotics give a increased risk of diabetes, and also create Parkinson's like symptoms. Right. So do you when you start looking at things like those things, or is that, do you look at that as being part of being schizophrenic? Is that you have diabetes because you take a lot of antipsychotic medication and that's a side effect and that's just part of the whole thing? Or do you see that as an inherently separate thing that it's just a coincidence that the person has the two things happening at once, right? You see what I'm saying? It's like, do we look at it? And what's kind of funny about this is that the word health, the etymology of where the word health comes from, it was related to wholeness, right? That to be healing is to be considered to be a movement towards wholeness, right? And yet when we do this thing, if you look at the person's physical ailments, their medical versus their psychological or psychiatric ailments, we have this tendency to look at it all as these separate things, and to look at these as these well-defined little pieces that sometimes show up together and sometimes they don't, and treating them as the unique little entities, but then not when you actually have a person who's a whole person who is experiencing life not as, they don't experience their life cut up and divided into all these different things. They experience their life all together. They experience all these different dynamics of what makes life in one big thing. And then it's only a doctor who comes along and who wants to zoom in on one little thing and diagnose it, and then use that to put the person in a different category, in a different box that separates them from everybody else, right? There's something about, another thing about the whole thing about the objectivity versus subjectivity. You could make the argument that a psychotic person does exhibit certain behaviors which are objective, in the sense that if you're acting out a certain behavior and it's other people are noticing it, other people are noticing you're acting strangely or chaotically or dangerously or something like that, or you're causing concern or something like that. It's the behavior itself has a certain degree of objectivity to it, but there's also a certain, I think the psychotic behaviors are maybe a little bit more ambiguous than something like an eating disorder behavior. I don't think eating disorder behaviors are ambiguous in the same way. But what I find interesting about the psychotic behaviors is that there's a certain predictable pattern to it oftentimes, or there's at least tropes. And I don't know, like the whole thing about the person who thinks that he's Jesus, or the person. There's another one that comes up a lot is like people get obsessed with these kind of alpha male figures like Elon Musk or something like that, and there might be a common delusion where a person like thinks they're like they make it. There's some sort of story they believe where they're destined for greatness or grandeur, or that like Elon Musk has secretly selected them to do a job for him, and that or something like that. I don't know. There's certain patterns which are like kind of in some way that like when your person is being diagnosed, they can say, "Oh, aha, yeah, see, we've seen this come up many times before, so you fit the pattern that we describe as being this illness," right? But the thing is, what I find there doesn't seem to be much effort made to understand the specific patterns themselves. And another one could be like the classic thing where the person behaves strangely, where they like strip off all their clothes and they go running naked through the street or something, right? Like if you do that, that's a pretty like classic. The person is not adhering to the normal social rules. They've gone crazy and they're acting in a way which is insane by our normal social standards, right? But I have to admit, I am recording this obviously as somebody who has experienced psychosis firsthand, and in my own experience, I recognize that, oh, I feel kind of odd. I'd better not act out these behaviors, because I could recognize that if I somehow gave in to some inclination to act strangely, I'd probably get in trouble for that. So you can kind of recognize that, okay, that could be a certain direction this could go, but I know better not to do that because I don't want to get into trouble. And by having that sort of, I think some people make the argument that you don't have as severe a case of psychosis if you're able to have this sort of like ability to detach from what's going on and say, yeah, I'm not going to strip down naked and go running through the street or paint funny things on the side of my car, or like, I'm not sure, but there's some kind of like, there's certain behaviors where you're like, I better not do these things so that people don't think I'm crazy, right? But the thing is that even if you have that degree of self-control, or to be able to discern between what sane behavior and insane behavior is, there's still this basic process at play which opens up. They're like a person who is not psychotic just wouldn't have to worry about that in the first place, right? But if you are experiencing a psychosis, even if you are able to maintain some self-control and not do these things, there's still some kind of like, you're still experiencing a state of mind in which you're like, oh, I better be careful. I don't do these things that people will judge me as being crazy for, right? And just because you're not doing those things that people would judge you to be crazy doesn't mean that the process itself doesn't just continue going in some way, right? Now, I've been doing some IFS therapy, although I have to admit, um, so far it's basically been having a therapist to talk to, having an outlet to talk about what's going on, so I'm not just bottling it all up. I don't know if I'm really getting to the parts work with this guy. I have been reading some IFS books and being journaling and trying to like observe my own, observe what's going on with myself from an IFS perspective, right? And there is a certain, I think this is like, a certain defense of the DSM has to do with understanding whatever the psychosis thing is as being inherently categorically different from these other kinds of ailments or these other kinds of maladies, and specifically, there's this thing in the IFS where they often talk about, let's say, binging, purging behaviors, right? And the whole idea of binging and purging could go with an addictive process. It could go with eating disorders, could go with self-harm, those kinds of behaviors. And the idea here is that people who have those kinds of problems have difficulty having self-control over those problems precisely because you could see that behavior is a kind of part that has its own autonomy. That there's some part that has its own. It's like that this part of you has its own will to do this kind of behavior, and that part can just take over and make you do things that you don't. That when somebody's in therapy, they're trying to make that better so that they don't do that, but the part, it's like there's this thing that has its own autonomy that doesn't so easily lend itself to being submitting to your willpower, right? Which is, in this context, it makes it a very different kind of issue than let's say take, for example, an eating disorder behavior like bulimia versus a psychotic behavior like taking off your clothes and running through the street. Right? Now, there is this, what I'm saying is that in my own experience, I don't know about other people, but in my own experience, I know maybe I just didn't have the impulse or the inclination to do that in the first place, right? You could also look at this another behavior of where you get the stubborn idea, you somehow think you're Jesus or something like this. That never happened to me either, right? So there's this sort of question there about, but it seems to me anyways, I honestly don't think that you can. I think there's some sort of something that's helpful, or at least you can redeem the DSM system of categorization in that I don't think thinking you are, like, if a person gets deluded by the idea that they identify themselves as being the savior or something like that, to me that just, it's obvious that is on a very different order of problem as not being able to stop yourself from binging and then purging or something like that, right? It seems to be very different kind of problem, and that the dynamic of having self-control over one of those things may be very different from the dynamic of having self-control over a different kind of thing, right? But the basic thing, I find the whole system be kind of frustrating because there's no effort to really understand what's going on with the psychotic behavior, other than just seeing that it could be potentially dangerous. Therefore, we just need to medicate it out of existence so that we don't have to deal with it, and not waste any time and energy on it, right? You could say that, in some cases, a person may have an addictive behavior where a certain like addiction to a certain substance leads to drug-induced psychosis, and that in that sense that it could be that the psychosis is actually part of the binge purge dynamic, right? Where the person is wrapped up in this binge purge cycle, but they don't act out a bulimic thing or something like this, but there's some kind of thing where a person is like so wrapped up in the consumption of a certain substance or a certain habit that there's some counter force which is like inherent to, it's like if you drink too much alcohol, you're going to vomit it up. And that's not about you being bulimic. That's just your body's own involuntary reflex. Your body detects that it has too much of this substance that it can handle, and it pukes it up. And that's actually being healthy. If you didn't do that, you'd be unhealthy, right? If you drank too much alcohol and you were not able to puke it up, you would poison yourself and die. So it's actually, in this context, it's healthy to have your body has this purge reflex healthy. It's just in a binge purge dynamic, it's a person is taking this thing that their body does naturally and reappropriating that to serve a certain purpose that we judge to be a pathological behavior, right? But if a person's body is actually puking up some poison, then that's a good thing. That's actually the body doing its job, right? It could be that if a person has gone too far using a certain substance, that there may be a counter effect of the psyche trying to be like, why, like, hey, you addict, why are you doing this so much? You need to stop doing, like, and if that part of the psyche which says, stop this addiction, it's bad for you, is not identified with, then that could be seen as an external force which is trying, like an external influence, which is trying to, which is acting counter to the will to just keep on with the addiction or keep on with the habit, right? And there could, but the thing is that there's this kind of problem that of when you're talking about psychosis, schizophrenia, the split mind, where the mind, there's something that is really your mind, but it's because it's split, you interpret it as being an external influence and not actually your own mind because you don't identify with it, right? It could just be your own conscious, like maybe a person's an addict but there's certain things, like I've never gotten into using lots of stimulants like crack and crystal meth or cocaine, but there are people you hear about, not just like when people abuse those substances and they have drug-induced psychosis, there are certain phenomena such as they talk about shadow people, which sounds really scary. Like, but I would basically look at this in terms of like the person has lowered their vibration, if you want to go new age with it, right? If you're using that kind of substance, you're lowering your vibration to such an extent that you're opening yourself up to low vibrational forces, and maybe the hallucinations or manifestations of that. But the thing is, it's like, the question is like, is the stuff that you're experiencing just your parts of your own psyche which you're dissociated from, or is there room for an actual externality there, right? And or is it just inherent to the substance? Is this just something that's inherent to the like the more you do this, the more you get this kind of experience, right? And it's just the substance itself. I can't speak about this directly because I have limited experience with stimulant kinds of stuff. I personally, I tend to be more of a weed head or a psychonaut, explorer of the psychedelic realm. I don't do that stuff anymore though, but I think I'm not going to deny that maybe that had a problem getting me in trouble, and that it could be that there's a kind of a balancing out the psyche, in the same way that if you ingest too much alcohol and you need to vomit, that you ingest too much of this substance and you need to have a balancing out mechanism to get you off the substance, to balance you out. That it could be actually the psychosis could be a renewal process, the psyche trying to heal itself, even if that's brought on by it's also interesting that there's an influence of psychedelics in the addictions recovery community, where oftentimes people who are trying to get over an alcohol addiction use psychedelics intentionally to bring in this dimension of some kind of consciousness that's not that works against the addictive habit. That using psychedelic substance helps the person break the cycle of addiction because it gives them a different consciousness, or there's some sort of influence that comes in there to help heal the person, right? And it could just be that it's like, there's a question, is that where does that influence come from? Is that some untapped potential within the self? Or is it, if the person if the person relates to that as something external to them, then it could be like some external being or God or entity trying to control them. But then if that external thing is trying to get them to be healthy, is that it's not really paranoia in that sense, right? If you've got these influences that are trying to get you to quit smoking, to quit doing drugs, to quit drinking, to clean up your act, then it could be maybe perhaps a spiritual, or like you could say that there's like some benevolent influence that's trying to help you to make better choices in life, and that there's actually a positive thing in it. right? Um, in the IFS perspective, there's this idea that you've got an exile part, you've got a manager part, and you've got a rescuer or a firefighter part, right? And that the addictive process is usually seen as there's the exile is some painful emotion that you don't want to feel, or some wound that you're struggling with, and the firefighter it gives you some relief through the use of an addictive habit or addictive substance, and then then there's this sort of like an inevitable consequence where if you do this too much, then there's some form of either regret, or maybe there's some consequence of it damaging your relationship or your employment or whatever it is. And then there's some kind of kickback where it could be like a self-critic, or a like, why did I mess my life up with this, or you feel sorry, there's self-pity, or it could be you could be beating yourself up for your bad habit or something like that. Or you could be I've seen this play out sometimes in actual group dynamics where it's like you have a bunch of people party, they all get hung over, and then the next day they have to go to work, and it's like, well, you fucking lazy asshole, we got to get to work, it's like this kind of like the when you wake up hungover, you're late for work, and you're like, oh fuck, why did I like this consciousness that comes back in the haze of the morning after, that you are ignoring your responsibilities, you are indulging for the sake of making this thing feel better, and then after that you get the bill the next day when you realize you just fucked something up and you feel bad, and then you're like, oh my god, I've just ruined my life, and I need to redeem, fix everything, and like there's so but that part it's all part of this kind of drama triangle of the manager, the firefighter, and the exile, right? Now the whole thing about like patterns of, let's say, self-harm or eating disorders or something like that, they basically use the same approach to understanding those behaviors, in that they are attempts at like soothing or relieving pressure, or trying to, even if they look self-destructive, that the patterns are, and the whole idea, they're trying to help, but the idea is that they've kind of developed a kind of autonomy to the point where the person who's struggling with them does not have control over them to the extent that they can just force them to stop, right? And so that's the IFS sort of like allows the part to have its own autonomy, rather than just trying to like use brute force to stop the part, right? And just kind of acknowledging that there is this part there that has kind of developed this kind of autonomy. But I think the question is like, how does this apply to psychosis, right? Because this whole thing is that there are behaviors in psychosis, but I don't think that psychosis reduces down to just a series of unusual behaviors. Because in my own experience, I could see that it's entirely possible to have a psychotic experience and stop yourself from doing certain actions. But maybe other people don't have that kind of self-control, right? But the whole thing is that, you could say like, okay, so if you're able to have psychosis and you're able to stop yourself from these kinds of behaviors, then what's going on there? What makes this an illness, right? Now, you have to consider the difference between bipolar mania and schizophrenia, right? Typically with schizophrenia, the idea is that the person has more of what's called negative symptoms, right? But regardless of negative symptoms, let's talk about the positive symptoms. Positive symptoms are positive in the sense that the presence of something being there, right? let's just talk about the most classic example that we do with psychosis is like hearing voices, right? The person who's experiencing hearing voices is the voice hearing is not a behavior, it's an experience, right? But there could be, you could use the IFS perspective to say that there is an I, a me, that is identified as the experiencer of this unusual phenomena. But that whole dynamic is different. Like a bulimic part is an active part. It's a part that is acting out a certain behavior which people judge to be pathological. A hearing voices part is passive. It's receptive in the sense that its whole problem is defined not by what it's doing, but what it is taking in the sense of a sensory experience, right? In the same way that a normal, quote unquote, healthy person would be experiencing the sights and sounds and smells and sensations of whatever is around them in their real material world. The person who is labeled as a schizophrenic, who is having hallucinations, is experiencing sensory phenomena that is private unto themselves, that the other people around them are not able to experience. And that in itself does not imply any behavior. It's simply just the taking in of some phenomenon, of some sensation, right? Now, the thing is that if the phenomenon is voice hearing is addressing the voice hearer as a subject, right? So the voice hearing, there's a subjectivity inherent in the voice hearing that is also somehow determinant of the actual quality of the voice hearing itself. Is the voice hearing, what is the actual content of the voice hearing? Is it negative? Is it disparaging? Is it bullying? Are the voices critics? Is the voices like antagonistic, or are the voices helpful? Are the voices encouraging? Are the voices giving advice which could be potentially helpful, or is the voices giving advice which could be potentially harmful? Right? There could be a voice that presents itself as being helpful, but then the voice is pushing you to do things which are crazy things, which if you were to carry out what the voice is telling you to do, then you know, maybe the voice isn't your friend. Maybe the voice is going to get you in trouble, right? But so there's this kind of thing. And then there becomes a link between a passive experience and an active experience. The issue around forced treatment with psychosis, if a person is just passively experiencing all these voices, aside from the fact that maybe that impedes on their functionality to some extent, that in itself isn't really what people tend to be concerned about. Is that person is going to act out in a way that's dangerous or destructive or something like that, right? And in this, I'm not gonna. I said I wasn't going to get into the medication conversation, but this tends to be why forced medication is used in psychosis, because there's a concern that the person's going to act out in some dangerous way, and that the argument is made that if the medication will prevent that kind of acting out from happening, right? So and then once if a person is acting out, then you've got behaviors, which could be I don't want to reduce all the behaviors out to simply just following the directions of a voice or something like that. But there could be there could also be a acting out as a way to try to mitigate or deal with it's like you get an input from all the things that you take in terms of the visions or voices and all this kind of stuff, and then you got different options. You either become catatonic, which is to avoid the problem of acting out and getting in trouble, you just don't do anything at all, and you become sedentary, You don't go out. You basically withdraw from society, withdraw from social circumstances, withdraw from activity, and this kind of characterizes what people consider to be schizophrenia, in that they may experience some hallucinations, but their coping mechanism is basically just to shut down and not do anything, right? Um, Whereas the manic person, and there's also, it's like, also like, you could also call that like psychotic depression maybe, right? Um, Mania is different because mania is the experience of having more energy to do something, right? You might have more energy to work on a creative project. You might have more energy for physical activity. A lot of people with bipolar become like, there's a certain, maybe a sex thing going on. People may have an increased libido or sexual activity. There may be all sorts of things to do with bipolar mania that involves becoming active, whether that's, and there is, but the thing is, it's like, I don't think I don't think it reduces down just to a behavioral pattern in the same way as like an addiction or a self-harm thing goes. And I think it's more complicated than just looking at it as a part or an autonomous complex that forms around a certain behavior, but rather the behaviors themselves are trying to take, in some, like, I'll just give an example of something that a way that I went and experienced a psychosis in 2012. I was living in Strathcona in Vancouver, a neighborhood which borders on Chinatown in Vancouver. And in this border between Strathcona and Chinatown, there is a Buddhist temple, a Buddhist church, in which they have a prayer wheel outside. And I can't say exactly what the effect. I had it in my mind that you have this experience where you're just overloaded by what you're experiencing in terms of input, right? That you are, as the part of you which is a psychotic experiencer, which is experiencing all these things that normal people don't experience, and just feeling overloaded by it. You're just like, what am I going to do with all this shit that I'm just inundated with, that nobody understands, or that if you try to talk to anybody about, they'll try to lock you up, or there's some need to act something out, but you don't want to act out destructively or in a way that's harmful, or in a way you don't want to get in trouble. But there's this idea, well, wait a minute, what if I use the Buddhist prayer wheel to act out, right? So in my state of psychosis, I went and I spun the prayer wheel. And it seemed to have some kind of effect on my experience. It didn't solve my problem for me. It didn't cure me of my situation, but that's not to say that it was just like it was just some sort of thing. You spin the prayer wheel, watch it spin around, and then it doesn't do anything for you. It does something, but you can't. It's kind of subtle. It's kind of hard to say specifically what that does, right? But there's a sense that by spinning, there's a sense that if you didn't spin the prayer wheel, it would have been different for some reason, right? Like, what happens if you were just overloaded with all this energy and you didn't go and spin the prayer wheel? And you didn't expend that energy on this gesture, this symbolic gesture that you're doing, whatever effect that has or it doesn't have. You just have all this potential energy and all this input in terms of symptoms or something like that you're experiencing, but you have no outlet for expressing yourself, expressing your energy. You're just like a bottle that's going to explode, right? Like that. It helps maybe to have certain outlets to express your energy, to express what's going on, right? But the thing is also, it's also in that situation, I only did that once. I don't even know if I've spun a prayer wheel since then. It's been over 10 years since I did that. I probably haven't spun I don't know, maybe, did I, it's possible I walked past that same wheel again. Did I give it a spin the second time? Or after that, when I was in a different state of mind? I don't think so. I think I only did that one time. Okay, I think I basically got through most of what I have sketched out here as my idea. I'm gonna leave it at that for now because I'm kind of getting tired of talking. And also, I mean, with this, the whole conversation is that it's kind of sensitive material, so I don't know. It's kind of questionable of whether or not I feel like, posting it, or I don't know. It is what it is. If I do end up posting this and you do end up listening to it, thanks for listening. Thanks for your support. And I don't know. Maybe we'll do more of this.